And we are live.
Oh, bummer. Hang on a minute, please. Okay, hope it didn't break. All right, so this is Senate Health and Welfare Committee. We're back live on January 18th, and we're moving from child care to healthcare reform and looking at the all-payer model. And we have with us the Director of Healthcare Reform in the Agency of Human Services, Ina Backus. And Ina, welcome. You have, I don't think you've been here yet this year, so we have a new committee. And so we're going to have the committee introduce themselves. We'll start with you, Senator Gullet.
Hello, I'm Martina Rock-Ulick. I'm senator I live in Burlington, and I'm for Chittenden Central. And nice to meet you.
Nice to be here. Yeah.
Good morning, Dave Weeks, Rowan County, live in Proctor.
Nice to meet you.
Nice to meet you.
Jerry Williams from Rowan County, I live in Pullman.
All right, and Senator Hardy will be in, and you know her from previous years, so this is great.
Yes.
So thank you for being here. Why don't you introduce yourself for the record, and then we would really like to hear, do you have something to share up on the screen, or?
I did send to, should I join the meeting?
Sure.
Via
If you can,
Zoom
yeah.
and share?
Yeah, that'd be good.
Happy to do that. For the record, my name is Ina Backus. I'm the Director of Healthcare Reform at the Agency of Human Services. I am the outgoing director, and I'll be joining Senator Welch's team starting next week, working in the Vermont office. It's nice, but it's nice to meet you today, and hopefully we'll see you in a different capacity in the future. I am from, so while you'll see how poorly I do with multitasking as I join and speak.
We don't believe that for a minute.
I live in Montpelier, but I grew up in Bristol, Vermont, New Haven, Bristol area. Let's see. Yeah, it is a pretty part of the state. Think of like Chittenden. Now that I live in Montpelier, Chittenden County feels like a banana boat. Like, so it's like warm and lake effect. And of course, I grew up in Addison County, but that whole side of the state. Okay. Okay, so I will share my screen.
And so just so you know, while you're getting that up for us, the new members of the committee haven't had experience with most of what we're doing here. So we'll have some basic questions as we go through. But we've got two things here for us. One is the all-payer model, and the other is the healthcare workforce update, which I'm thrilled that we can both of them. That's great. You know, there's a lot of interest in both. So which one we're starting out with?
I don't know why I'm having difficulty. It's just. I'll try screen sharing one more time. I'm sorry.
Yes.
I was just doing it in the other committee. I'm not sure what's happening here. Okay. Share. Okay. Thank you. Great.
There's something up there. Yes.
Yes.
Are we starting with all payer or with workforce?
It's your preference. Either works.
Let's start with all payer, and then we'll go to workforce. And just so you know, it would be great if we could wrap up probably with 5 minutes to spare. That would be helpful.
Okay. And I see that I'm joined by my colleague, Wendy Trafton, on the remote. I'm going to welcome her as well.
Yeah, good. And if you'd like to introduce her for the record, that'd be great.
Yes, thank you. For the record, my name is Wendy Trafton, and I'm the Deputy Director of Healthcare Reform within the Agency of Human Services. Thank you.
Thanks for being here. We appreciate it. Really. You may get some questions.
Okay, so the intent of our conversation today is to talk about Act 167 of 2022, which asks that the Director of Healthcare Reform continue work to explore a potential future all-payer model agreement. And we're moving to calling this multi-payer model as we have our conversations with our federal partners. And in fact, Act 167 uses the terminology multi-payer, which is great. But I know that people have heard a lot about the all-payer agreement, and we do have a contract with the federal government today that is called the Vermont All-Payer Accountable Care Organization Model Agreement. But as we continue, and as we continue to talk about this with other folks, you'll hear the term multi-payer being used more frequently. Now, 167 asks that the Director of Healthcare Reform collaborate with the Green Mountain Care Board to continue to look at and develop a proposal for what a future or subsequent agreement with our federal partners would look like and what the state would want to propose. Now, I'll back up a little bit to just give a very high level explanation of the agreement that we have today. We, since 2016, the state of Vermont has had a contract with the federal government so that Medicare can pay differently for healthcare in the state of Vermont. And it does that through an accountable care organization model. The contract has 3 signatories, the governor, the secretary of the Agency of Human Services, and the Green Mountain Care Board. All 3 of those signatories agree that in exchange for Medicare doing its business differently in the state of Vermont, that the state of Vermont will meet a number of requirements, including that the Green Mountain Care Board sets the rate that Medicare grows in this model. The Green Mountain Care Board helps to define how Medicare pays and aligns with other of the payers in the model. And the Agency of Human Services, which is where I work, the Director of Healthcare Reform, but also has 6 departments. I think you've had the introduction. The Department of Vermont Health Access, one of the agency's 6 departments, is and administers the Medicaid ACO program, which is aligned in this all-payer model that we have. And we are required to offer that program by this state federal agreement. And then the state federal agreement really strongly encourages that commercial payers in the state also pay differently for healthcare in this model. And the reason that we have used this terminology all payer in the past, the reason why we'll continue to use a multi-payer terminology going forward is because fundamentally we're talking about shifting the payment model for healthcare services. And the payment model in the United States, there are numerous payers, so many different payers that contract with providers. Commercial insurers, Medicare, and Medicaid represent 3 broad categories of payers. And the model is trying to get those 3 broad categories of payers to align in a different reimbursement model for healthcare services. That's.
Can you just, I'll ask you, are you going to talk about a distinction between fee-for-service and our multi-payer system?
I can absolutely do. I don't have it in this presentation, but I have it in another one, and I can toggle I could show a slide even, that would be helpful if you
Yeah.
want.
Just a quick explanation of the differences would be helpful, then we'll be on the same page. Because when you say multiplayer, it means one thing to me, but it might mean something unknown to somebody.
Someone said a page was needed in room 17.
Yeah, one of your colleagues just took the,
Okay.
yeah, thank you very much.
I love these.
Those- they're courageous.
Kind of doesn't feel professional.
Yes.
Can you all see this?
Yes, yeah.
This is something that's called, it's such a boring name. It's a learning action network, alternative payment model framework. And this learning action network is something, it was set up partly by the Affordable Care Act, and it supports the federal government and the Center for Medicare and Medicaid Innovation, which Vermont works with really regularly to think about alternative to fee for service. And it was really set up because the Affordable Care Act anticipated that in order to bring healthcare costs under control in the United States, that we would need to explore and consider a lot of different models of reimbursement other than just the fee for service reimbursement model. And so the Learning and Action Network set about to create a framework of, if it's our goal to move away from fee for service, here's a framework of different categories of healthcare payment models that are moving away from fee for service. But the essential point is that with the fee for service reimbursement model, that model pays for healthcare services that are administered. There's a payment for each and every service that's administered, each and every service that's billed. And that payment is provided regardless of whether the service is contributing to better health outcomes, regardless of whether the service is a high quality service or the most appropriate service in the right setting of care. And again, the Learning Action Network and federal partners all hypothesize that that needs to change in order for the healthcare system to better meet the needs of individuals in our country. And here in Vermont, we hypothesize that to be the case for the citizens of our state. So then we would want to start to move away from the fee for service reimbursement model to a model that does reimbursement, that does have a link to quality and value for people. And there are 3 categories of payments that can be defined as having links to quality and value. And that includes investing more in category 2, investing more in quality performance, paying fee for service, but accompanying that with bonus payments for quality, or accompanying that with infrastructure payments for supporting, let's say, primary care providers in offering more comprehensive care and connecting to community-based care. And then there's also, in terms of the healthcare payment and reimbursement system, there's a strong theory that risk and holding risk is an important component in better managing overall costs for the system, and that if more risk is transferred to healthcare providers rather than sitting with third-party payers exclusively, that the healthcare providers will have a stronger incentive to provide the most high quality, most appropriate care versus any care that, any care, and they're going to be reimbursed for that regardless. The other key component of why we want to test this move away from fee for service is that fee for service is a very rigid model, and it's based around how providers and their particular services are kind of valued relative to the time it takes to perform the service, the training, the materials needed for the service, and so on and so forth. But the reality is that providers' time in speaking with their colleagues about best practices, providers' time in following up with people by phone, checking in with their patients, having enough time to sit with their patients and have a complete kind of conversation and understand and look people in the eye and provide for care. Those things are not typically reimbursed. So there's no payment for spending your time that way. So that's another motivating factor in moving away from the fee-for-service model. And when you move all the way into category 4, which is the furthest from fee-for-service and is really setting a budget for providers, a predictable payment for taking care of a population of individuals, then again, the hypothesis is that really allows for more flexibility for providers to meet the needs of their patients in the most appropriate way. And I think it's, this is how the system has been set up, and any individual provider is not, they're always, for the most part, always working in the clinical best interests of their patients, but they are working in a system that may limit their time with a patient, that may mean that any opportunity they have to make a phone call to a patient isn't until 11 p.m. at night when they've finished all their other paperwork.
Yes.
So there's system. The system is what we're really looking at. We're looking at the lens of reforming the system so that it can be, so that it is a better working environment for clinical individuals to provide the best possible care.
And for the patients too, right?
Yes. The first objective is to improve the patient experience of care. Yes.
Cost, quality, access.
Yes. And quality includes how you experience care in the system.
Just like childcare.
Yeah, it's like, oh, geez.
Yeah, right?
We're getting that. So why don't we just go back and we'll, I think ultimately we'll all have a discussion in here,
Yes.
sort ourselves out somehow. It's great.
So we've been working in this model to move away from fee for service. That's the basic premise of the model, moving away from fee for service. And that contract has been in place. It has 5 performance years in the original agreement, and it included 1 year that was called a year 0 and wasn't a performance year. So it was 20. I actually have a quick, if you don't mind me toggling back and forth between presentations, there's a timeline of the original agreement term. We're currently in an extension of this agreement because of a couple of key factors. Our agreement and the timeline for us to propose a future potential agreement happened to be in the time that we had a global health we had a pandemic, and we still do. So that made the work that we needed to do with stakeholders and with Vermonters, and certainly thinking about the providers who are already experiencing this change in the system and wanting them to be able to come to the table to think about what's next, we needed to delay that work. So that's why we have an extension of this current agreement. And we have an additional year. We're in an active extension now, and we're likely to, we will be offered an additional year. And that is because our federal partners anticipate that a new model wouldn't be available until 2025. Okay, I'm going to go back to the presentation. That's the update.
Good, yeah, good. Thank you. Thanks for digressing.
I'm happy to, as long as you don't mind me toggling back and forth here. I don't move as fast in Zoom. Every time I'm like, am I doing it right? Okay, so we've been tasked now that we have an extension, we've been tasked with doing the work that I just referred to think about a future potential model. And I wanted to highlight the work that we initiated over the summertime with the healthcare, what's called the Healthcare Reform Work Group. And that work group is and has been, and we'll walk through what work it did over summer and fall, looking at a future financial and care model. We're thinking of it as a future financial and care model. But I did want to make sure that the committee understood that in order for us to really get to that work, we also had to spend some time with healthcare stakeholders addressing some very short-term stability issues. The pandemic certainly disrupted, as everyone knows, all aspects of life, but then had some very particular disruptions to the healthcare system. And it's been important that we spend time strategizing about some things that can be done in the short term to alleviate the pressures that have come to bear on the system. And we also talked about some of the impact of the federal regulatory environment and how that is, and that environment is in some ways exacerbating those pressures by cuts to home health providers, for example, by sunsetting some really helpful waivers that allowed skilled nursing facilities to be able to meet the needs of their residents and patients in some more creative ways. Now they cannot do that because the waivers that were in operation during the pandemic have closed, and and other states and other places are struggling too. So we've advocated with our federal partners about those regulatory changes that are creating continued challenge and pressure. And then talking about the financial and care model that we would want to pursue in the future if we want to continue having Medicare be a part of all payer reforms. Just a very high level summary of what the work group did in terms of the summertime work. They generated recommendations in terms of short-term stability in these key areas, and you can certainly dive deeper into that as you choose in future conversations. But I'm highlighting this here, and then moving to the financial and care model. So that's what Act 167 was precise in asking us to do, is develop that future potential all-payer, multi-payer model, and to propose a subsequent agreement for Medicare's participation. And Medicare's participation in paying differently is really critical, with Medicare, being for many hospitals in the state, Medicare represents 39% of their total revenue. Green Mountain Care Board has a great chart that lays out how much revenue from Medicare each and every hospital in the state receives. If we're thinking about paying differently and Medicare doesn't pay differently too, then we're missing at least, like you could say, a third or more of the payments. And then that's not a very consistent signal for the providers if Medicare doesn't pay differently. So that's why we're continuing to pursue Medicare as a partner here. The work group met between August 25th and November 29th on this particular topic, how we would continue to engage with the Center for Medicare and Medicaid Innovation for Medicare future participation. And during that time, we had 2 subgroups that did specific work relative to global budgets, as well as total cost of care, which is what the total cost of care is a high level target. If you roll up all the services and spending in a state, how much does it cost and how much should it grow over time?
What is the 7 and 5?
There were 7 meetings.
Oh,
And 5.
okay.
meetings.
I thought that was how you named the groups, like there were 7 people and 5.
Oh, that would have been like hip and cool.
Are you 5 or are you 7? I'm 7.
And so this is a little bit more of a timeline for what we expect in terms of we had an agreement, we signed the extension for that agreement in November of 2022. Now we have an amended and restated agreement that will operate in, and then a future potential agreement would take effect in 25. And we're looking at approaching this work in 3 phases, and we've done the first phase of work, which I discussed, where we talked over the course of those meetings with healthcare stakeholders in the state. And specifically, we were working on a very regular basis with this group to solicit their feedback, because it was our understanding at the time that our partners in the federal government weren't going to engage with us past January. So we thought we would be ending our opportunity to inform our federal partners about what a next model would look like. So we were rapidly soliciting feedback in a number of areas. And I'm gonna go back and forth here. In these 7 areas, which our federal partners said have to be components of a future model. So and these components are going to look, I think, familiar, especially because Act 167 has a requirement for developing methodologies around global payments and global budgets. Our federal partners looking at how Medicare will participate in the future in these state models, what they're putting forward to us, as well as other states that have these models today, Maryland and Pennsylvania, is that a future Medicare alternative payment model that's customized for a state will include a global budget component for hospitals. It will also need to include a statewide total cost of care target that is likely, there would be a multi-payer target, and there would be, or an all-payer target in that case, and a Medicare specific target, because Medicare in these models is keenly interested in its spending. That there be multi-payer participation across those 3 groups, commercial insurance, Medicaid, and Medicare. That there be goals in a future model for minimum primary care investment. That there be inclusion of safety net providers from the start of an agreement, and that means potentially federally qualified health centers are safety net providers. They participate in our model today, but also critical access hospitals are considered, can be considered as a part of the safety net. That a model would address mental health, substance use disorder, and social determinants of health or health-related social needs. It is very refreshing.
Doesn't it smell good?
I'm sorry.
No, it's wonderful. It's great.
We can't have oranges in my other committee because one of my.
I don't have any others. These I brought from home, and I apologize to my committee. And there's chocolate.
Chocolate and oranges go so well together. Yeah.
Since we interrupted, can I ask you a question about, first of all, I assume your slides, we have them on our website.
Yes, they're right here.
Could you print me a copy of her slides? Are there anything in the, if I may, Madam Chair, I'm sorry.
As long as it doesn't deviate too far.
No, I think I love this list. And are there other things that are required or you think may be required regarding, I'm thinking of the specifics of payment and payer and sort of around what an ACO or what an alternative to an ACO may have to do. I don't know if I'm being clear, but
That's clear. Yeah. Well, so these are, I think there's a lot of alignment between Vermont in terms of what this legislative body has discussed, what we've discussed with stakeholders, you know, in our current model of what we're doing today with these priorities, which are our federal government, you know, these priorities are CMMI's priorities. CMMI and Medicare, you know, Medicare has numerous ACO programs that it offers, and that there are, you know, more than, there's between 700 and 850 ACOs in the country that are participating in the Medicare ACO program. So there's a large number of ACOs across the country, and I think that from Medicare's perspective, it's trying to consider how a model could potentially allow their global budgets for hospitals without excluding necessarily hospitals that might be in an ACO model, if that makes sense.
Yeah.
Because they're concerned that their models can't always be exclusive of each other, if that makes sense.
Yeah, that's not exactly what I'm getting at, and maybe you and I should have an offline conversation, because I'm trying to wrap.
Is your question, do we need an ACO in order to accomplish our goals?
Well, ultimately, yeah, but
Yeah, so that.
But if we do have an ACO or whatever we have that may be a different thing than an ACO, are there parameters for how that will work? Because right now, we have an ACO that isn't doing what we thought it was supposed to have done. And trying to put tighter guidelines on
So
that.
Senator, now we're getting.
Yeah, so you and I can
We'll
talk.
come back to that, and I know we're gonna have that conversation
Thank
as
you.
we get to ACO.
Accountable Care Organization.
Thank you.
Accountable Care Organization is a group of providers that agree to work together to coordinate around the delivery of patient care and to be accountable for the cost and the quality of that care. So the providers come together in a legal arrangement, which is under the, you know, kind of the Accountable Care Organization model, and then do that work together. It's
Complicated, different from an HMO.
It's one
It is.
pair in Vermont.
Okay.
So here's what I'm gonna suggest. We're moving off of where we wanna be right now, and we're moving into a different discussion. I'll let one more question happen, and then I think we're just gonna listen to you present your slides, because I'm very aware of the time, and I know that you are moving to a new position with Senator Welch, and I don't know when we'll ever get you back.
and Wendy and I have so many great workforce updates too.
I know,
Healthcare
and we want
workforce
that.
updates.
If we don't get to it, maybe Wendy will share it with us if we don't get to it today.
Absolutely, yes. And you have a handy chart too.
Good, okay. Senator Weeks, one question.
No question.
Good, oh, bless you. All right,
Okay, so I'll go backwards now a little bit here. We talked about paying differently than fee for service. One of the ways that you can pay differently than fee for service is through an ACO model, where the Accountable Care Organization is responsible for a total cost of care for a population of payments, and the Accountable Care Organization receives the alternative payment, you know, that's contracted with the payers, or so that is the model that we're working in today. And we've been, you know, accountable care organizations have been active in the state since 2012. One Care Vermont is the accountable care organization that participates in the all payer model agreement. There is another accountable care organization that has had a budget review by the Green Mountain Care Board. And there have been a couple of other accountable care organizations at different periods of time and are not active today. But there is one other active one called Lore Healthcare, and it has one Vermont provider group that participates in it. So when we're thinking about what would it mean for Vermont to continue in an alternative payment model with Medicare specifically, which is part of what we are tasked with doing, the work group over the summertime elevated some really key considerations that we have then in turn been trying to advocate with CMMI, which is the federal partner. Vermont has a number of factors that make it really critical that we consider what Medicare does differently with our state. The first is we're one of the oldest states in the nation, and we're also rapidly aging in Vermont. And this would suggest that we might see higher Medicare costs in our state. In fact, we are the lowest spending Medicare state in the nation. We're also, even in spite of being an older and aging state, we also consistently rank as one of the healthiest states in the nation. Vermont has been engaged in iterative healthcare reform over many, many years. And these healthcare reform initiatives that are shown here in this chart are specific payment and delivery initiatives. I also want to acknowledge all of the work that Vermont has done in other healthcare reform projects, like expanding coverage and wraparound services and supports for individuals, Medicaid program that we have through our 1115 waiver that allows Vermont to do a lot of very unique investments in services and supports that otherwise wouldn't be paid for. So we have, in our state, a history of many iterative reform pieces that I think taken together are impacting the health and the cost of care. That does not mean that we can't, and that it does not mean that care is at a place where people would view it as affordable, that people would view their experiences as being the best possible experience. We have continual work to do here. But when we think about doing that work with Medicare specifically, it's really important that we get some credit for what we have achieved and that we get Medicare to agree that it will continue to sustain some of the real innovative work that we've done in the Blueprint for Health, for example, which Medicare is paying for now through the current contract that we have. So we really want to ensure that our partners understand that we're overperforming relative to other states. And it's critical that that understanding is there. Sorry for toggling around so much, because we are at a point with our system, which I reflected on early in the presentation, where the system is not stable. And the United States is having a challenging time in healthcare across the board. There's no doubt about it. But Vermont's healthcare cost containment efforts with Medicare in particular, we've bent that cost growth curve since we entered this model agreement. And we've instead of growing more rapidly than national healthcare with Medicare, which we're growing consistently through all of the years of this agreement. We're growing less quickly. So when we have achieved what we set out to do in that 2016 contract that we signed, we've achieved that with respect to Medicare. If we continue to do more with Medicare and to grow, to continue to need to grow less quickly than the nation, we will be doing a disservice. That will not make our system sustainable. It will impact the sustainability of our provider system. A future Medicare payment model for Vermont, when we look towards the next model, it has to reflect the actual costs to deliver care. It has to provide financial sustainability for participants. If we we think about how these budgets are set. If you set a global budget for a hospital, for example, based on this year, where so many are ending the year in the red, there's no way that looking forward that's going to be sustainable. And we really need our partners in Medicare to understand this critically. We've also, like I said, maintained growth that's lower than the national average, and we would like to get some credit for that. So money back.
Which we never do.
Which we never do.
Literal credit.
Investments,
Yeah.
yes.
Well,
And-
the other thing, I just want to say that Vermont has been a leader in all of this.
Yes.
Across the country. And
Yeah.
regardless of your feelings about individual components of the system, that this has been a real, it's been a help to other states and to CMMI.
Yes.
But it would be great to get some benefit.
And CMMI is I think that I can say, that like there's a recognition, it's not from CMMI itself, but there's a recognition at the federal level that Medicare in particular hasn't kept pace with investing in primary care.
Mhm.
And I think that's something where there's been, a lot of work on it. There's a relatively new 2021 report from the National Academies of Engineering, Science, and Medicine that recommends that the federal government needs to step up its investment in primary care specifically. So I think we have some shared values. Yeah. So the work group, I'm going to give a high level, just kind of summary of this subgroup activities of this work group, because the Green Mountain Care Board is going to talk a lot more in depth about the global budget development methodology, which we've been doing all of this work with them in partnership. The global budget subgroups that spun out of the healthcare reform work group, we co-facilitated those with the Green Mountain Care Board. There's going to be a new, even deeper in the weeds, global budget for hospital technical group that's launching, and we will co-lead. I say we, I won't be there, but others in the Agency of Human Services will be co-leading this work with Green Mountain Care Board. And we are working as close partners with Green Mountain Care Board as Act 167 requires, but also in close partnership because the hospital sustainability work is critical, and there is a very strong relationship to the work that we do with our federal partners in terms of long-term stability for hospitals, which I just referenced. If we're working in a Medicare model that doesn't support the long-term stability of our hospitals, as our state ages more rapidly and is older than others, that's very problematic. So we think that in the global budget aspect, we would like to see as much flexibility as possible from our federal partners to set the model for hospitals so that the way that the state today can influence how the ACO program works, that the state would have influence and flexibility in a potential global budget model that would be for hospitals. Those have been key objectives, and other states join us in that perspective. It's probably not surprising. Why wouldn't the states want more flexibility? But I do think that we have good company with those other states that are likely to work with CMMI in advocating that the global budget model for hospitals not be rigidly prescribed from the federal level. I think that will be difficult. There's some difficulty today already in a number of CMS models that have been put out. Those models are so rigid and are a bit of a black box that I think there's been, hospitals have declined to participate. So I think we need transparency and flexibility. So as this work continues, there will be ongoing weekly meetings with CMMI. One of our places where we advocated with CMMI strongly was to say that we weren't ready yet to stop talking with them. They wanted to stop but they felt that for their clearance process to be effective and to be able to offer a next potential model, that they would need to stop engaging with states starting now. Instead, we've advocated that we need a lot more conversation with them, and they will continue engaging with the state of Vermont through the summertime. So we'll continue meeting with them. The state of Vermont also has a regular monthly meeting with the director of the Innovation Center. The state of Vermont is co-launching this more deep in the weeds technical global budget work group. We're also going to launch, and this is a place where Wendy has really been lead in thinking about when part of why we seek these partnerships with Medicare specifically to do things differently is Medicare also has some really rigid rules around reimbursement, regulatory rules, who can bill Medicare. For example, if you're going to go to a skilled nursing facility, an original Medicare, you can't go to that skilled nursing facility and have Medicare pay for it unless you've been admitted first to the hospital. In the model that we're operating today, the ACO model, the person's Medicare beneficiaries can go directly to a skilled nursing facility through a waiver. We want to explore how well the waivers that are in place today are working. We want to look at waivers that are in place through other ACO models, because there is a new ACO model that's called the REACH ACO model, and that provides waivers that allow nurse practitioners and other advanced practice professionals to bill Medicare. And we want to look at what waivers had we not considered that we think are crucial. One of the areas we've highlighted is Medicare paying for licensed mental health and substance use disorder clinicians, whereas right now they're more limited in paying for master's level social work versus licensed alcohol and drug abuse counselors, for example. There has been, Congress has taken action to expand Medicare's reimbursements of mental health and substance use disorder professionals. And what we need to do is determine what gaps still remain even after Congress has taken action. We think there still may be some gaps, and we would be interested in seeing if we can fill those with a custom model. So that work group will be fun. And
Yes, it will. I'm with you. It sounds like very fun.
And then from there, there's going to be a much broader engagement of the public and of citizens on this topic through town hall meetings and other forums to share what we've learned, to share the frameworks that are being considered or under consideration, and to gather that feedback.
We're really close.
This was my last slide in terms of the update.
Good, yeah.
And we did have the workforce update for you as well, but I'm not sure that.
Do you have that one,
The grid?
I mean, what makes sense? I would like to give everyone, I need a minute, that's all. I guess I'm being selfish. So why don't you go ahead and we'll see where we get with for a minute.
I think we could do an overview of it pretty quickly. And I might ask Wendy if she can share her screen on the grid, because I don't have it pulled up currently on my computer, if that's faster. I don't know if you do, Wendy. It's okay if you don't.
Whatever you think is most efficient with the small amount of time we have. And Wendy, we can bring you back if you don't mind, as we look at this. We can't see that.
You can't see that. You can't see it because it's too small or because it's
If you just magnify.
There we go.
There we go. That's good. Correct. Good. Perfect.
Okay, so this will be switching gears to initiatives that were put forward in Act 183 of 2022 to support the healthcare workforce. Like we've talked about the disruption from COVID-19 and the particular ways that that's impacted healthcare providers. I think you probably have understand that the healthcare workforce, typically when there are huge economic disruptions, recessions, depressions, the healthcare workforce actually remains fairly stable and can even grow during these times. Healthcare has been a growth sector. It's been one of those sectors where people are encouraged to pursue, opportunities because of that growth. With the pandemic, which was a public health emergency, that certainly has changed the healthcare workforce in huge ways. And so Act 183 is a whole, and the overall workforce. Act 183 legislation sought to provide for investments to improve Vermont's workforce across the board, and then in particular with some ways relative to the healthcare workforce. The first activity was for there to be emergency grants that would support nurse faculty and staff. So these are educators who would be training and educating future nurse workforce. And the deliverable here, this is a $2 million investment with emergency interim grants to Vermont's nursing schools over 3 years to be the deliverable. This was something where the Vermont Department of Health was responsible for this activity. And this activity and all of these investments were funded through state fiscal recovery funds, federal funds for coronavirus relief, but not coronavirus relief funds, state fiscal recovery funds. And these, so this is something where working within the SFR requirements, BDH has sought to determine whether the nursing schools can meet the expectations for the state fiscal recovery funds. And once that assessment is complete, they're going to take the next steps to try to issue these funds. You may have heard that the state fiscal recovery funds, and certainly I invite Wendy, who's worked with these much more extensively than me. Speaking of rigidity and requirements, there are some very narrow ways that you can meet the requirements in order to use these funds appropriately and in compliance with the federal rules and guidelines.
So here's what I'm going to suggest. I think there's enough here and enough activity going on outside in our various institutions and communities that it would be great if we could have Wendy come in and do a deep dive, unless you want to return and do that.
Wendy is the expert.
Sounds like Wendy is the expert. And Wendy, can we have you schedule in with Alex and have you come in on this? Because this is a big deal. And we'll also be looking later on in the session about what do we need to continue, what more needs appropriation, and so on. So having your expertise and bringing in the information would be terrific.
Yeah, so we like this partnered with an understanding of where the premium paid program is going. I realize that this one is focused on Act 183, or happy to talk with Alex about the best steps in our next testimony.
Terrific, thank you so much. And Ina, thank you. We are going to miss you, but we'll see you in another capacity, most likely. Ina is moving on to become, what is going to be your title?
The title is Outreach Representative, which means I'll manage the Health and Human Services portfolio for the Vermont office of Senator Welch.
Just a minor job. Huge. Thank you. Yeah, your work has been exceptional, and we're going to miss you a great deal. Yeah.
Thank you.
And thank you for today. This is good. This is a good start, good introduction. We'll be coming back to every single bit of it in one way or another, so it's good.